Thank you very much, sir. It's a privilege to be here for another session. I hope my screen is visible. Um, we have had such sessions almost every third Friday since last few months, and this time we have another excellent speaker with us. Uh, the speaker which we have today is Dr. Martina with us, and she is a director of professional education at Cooper Surgical's Fertility Solution. On front of education and training, she has her PhD in medical sciences from Free University of Brussels in Belgium. She is an HRA certified clinical embryologist, and she has MSc in anthropogenetic from again Brussels and BSc in biological sciences. With regards to academic contributions, she has authored over 100 peer-reviewed articles and book chapters and Edge Index of 30, which means she's well read and well reached out to a lot of other people. She's currently working as a professional education, director of professional education as Cooper, and she coordinates a lot of such training sessions. Thank you, Martina, for being available with us in today's session as well. On the career progression, she is clinical embryologist, senior clinical embryologist to IVF lab director and the scientific director. She has gone a huge journey. She has co-founded and directed the Embryo Lab Academy in Greece, and she has managed laboratory in Belgium, UK, and Netherlands at various levels. She has been on editorial board. She has been associate editor for Human Fertility, and she has numerous lectures at global conferences behind her. We also had one of the sessions a few years back for her team.
I exactly remember that. That was quite an interesting session.
Yes. So we look forward for an exciting session. PGT is new norms. A lot of people are getting trained in PGT. Though the NI PGT came up, but the PGT still stays as the golden standard. And we feel with your lecture today, all these people who are looking forward to get themselves validated in PhD or who are also validated will get good insights for their practice on the PhD. So.
And yes, especially like I have a keen interest in PGT, and I can understand the importance of tubing because everybody, most of the time, embryologists, they emphasize much more on the technique of biopsying the embryo, biopsying or the trophectoderm cells. But tubing is a very essential part, and it is as important as doing the biopsy procedure. And so today, Martine is going to highlight what all care needs to be stress needs to be put on while tubing and how the best tubing can be achieved. So over to you, Martine.
Thank you so much, Dr. Shah and Dr. Agarwal, for your kind introduction, and to the India Clinic for inviting me. I will start sharing my screen if that's okay with you.
Sure.
Okay. And thank you all participants for joining. It's really a pleasure to be here with so many people attending. Today I will focus on how to excel in cell preparation for PGT. I will also zoom in a little bit on the PGT process first. Then I will describe a little bit the laboratory conditions because they are essential for the biopsy, but very essential for doing that excellent tubing. I'll discuss a little bit the state-of-the-art good laboratory practices for biopsying cells, and then we'll zoom into how to prep cells so that they can be usefully used in the genomics testing lab and result in a correct test result for the patient. I'll briefly touch on no results in PGT as well, and then I will go through the factors we know now that can influence your PGT result. I'll summarize and show you some more educational material that you can have a look at when you have the time, etc. So we all know the PGT process. This is a brief overview of the three different cellular biopsy techniques that are out there. We have moved away from the day 3, so the cleavage stage embryo biopsy. We're now doing more and more TE biopsy, trophectoderm biopsy. The whole idea is to bring that cellular material from our biopsy into a vial, and that's most of the time a PCR tube, and then store it and ship it to the genomics provider, the testing lab, where they will then look for abnormalities, monogenetic diseases, structural chromosomal rearrangements, or aneuploidy screening. In the meantime, the embryos need to be cryopreserved by vitrification because this testing takes more than 1 to 2 days. And we also now see a new set of patients coming to our clinics who have embryos cryopreserved. And they say, okay, we now want our transfer, but we also want PGT-A applied to the embryos. So that's a different set of embryos that we're going to work with. These are already frozen. We need to thaw or warm them, do the biopsy, and then re-vitrify them whilst the test result is being prepared. Once we have the test result, we can select the embryo that we are going to transfer. Is this a new technique, taking the trophectoderm cells? No. This is the first publication, the first feasibility testing for this technique that was done in Australia, where they, as you can see, used a needle, a glass needle, to cut away as part of the zona. There was a large chunk of cells that were hatching. They removed the cells with the needle again, and then cultured both, and they saw that both continued to develop. And so they concluded this is a feasible technique. The embryo survives and the cells can be used for genetic testing. And a few years later, in 2002 and 2005, they presented their first pregnancies and healthy babies. And the technique they used was assisted hatching with the laser on day 3, then biopsying 5 to 6 cells from the trophectoderm, when the hatching was there, and then use the laser and pull technique or the laser and flick technique. They used PCR and fish after they had washed the cells 3 times in a buffer. And well, you can see images of those publications at the time. So this was in the 2005. Are we using this technique now a lot? And these data come from ICMART. This is the Global Data Collection Consortium that were presented at the ESHRE meeting in Paris this year. And as you can see, we have over 155,000 embryo transfers that result after PGT. These are the 3 indications, I have to say, not only PGT-A. Also, the data from China are not included, but they result in a 48% delivery rate per transfer. And if you look 2 lines up, there you see the fresh transfer, autolog fresh transfer. There you have a delivery rate of 25, well, almost 26% per embryo transfer. So there is definitely an efficient way of selecting the embryo at the highest chance to implant and to result in a healthy delivery. So now let's go into our lab and see what the lab conditions are to be. If you are doing pre-implantation genetic testing, that will definitely change the workflow in your lab. You may need to install new equipment because you will do more work. There might be a clash when you are wanting to do the biopsy and somebody else is doing ICSI. So time-wise, you might need to invest in extra ICSI rigs. You need that area, that safe space that is clean, DNA-free, because we don't want to contaminate our samples. We need to have an optimal IVF lab with high blastocyst rate and a perfect working vitrification warming system. Otherwise, the PGT that will use both, that will not improve the results. On the other hand, you will have a negative impact on your outcomes. It's for the lab to decide, the clinic to decide what their policy, their view is on when to biopsy. You can do different time points for that same patient when cells are hatching. What we see now is that people are moving more to a day 6 biopsy, simultaneous opening of the zona pellucida, so no assisted hatching, and then aspirating those, biopsying those cells. But that's for your clinic to decide what works the best for you, after, of course, a big validation and testing round. People need to be trained, the operators need to be trained, and as the moderator rightly said in the beginning, it is not just the TE biopsy, it is also that very important high precision preparation of the cells that were biopsied and delivering those to the genetic lab. Changes in your lab are also, maybe you do this already, you need to go to individual embryo culture. You need to be able to identify embryo number 1 and distinguish it from embryo number 2. So these are separate patients, as I call them. And then this could be a different culture system that you're currently using. So before you move into this, you need to validate. This could mean more dishes in your incubators, could mean more door openings of those incubators. So a less favorable conditions for those patients not undergoing a PGT cycle. Those embryos are also exposed to that same environment. Some people are culturing now embryos to day 7, the slower growing embryos. So this is again more dishes in your incubators. Do you need to change the medium in this situation for you to validate and see and check how that works? Time lapse, of course, is an ideal culture system for this. You don't need to go in, you can observe remotely and then select and choose the moments when you are going. But still, one should have a think about changing the medium if you are going to do this very prolonged embryo culture. We need excellent equipment, as I mentioned in the beginning, and the tool is, of course, your micromanipulation setup that needs to be well maintained and validated for temperature, that there are no temperature shocks or peaks while you are doing the biopsy. And your injectors need to be also well maintained. They could be air-driven or oil. I work with air, it works really well, but it works slightly different, but it's a training. So once you know how that works, it's really easy to take the cells. Ideally, you also have a screen so you can discuss with your colleague and discuss how to approach the biopsy of a specific embryo. And a laser is, of course, also essential in this work. This overview on the types of biopsy methods or the moments of biopsy method comes from the really very nice overview, the ESHRE PGT Consortium and SIG Embryology Good Practice Recommendations for PGT. I advise you to read it. It has all the necessary information for good laboratory practices around this specific technique. And as you can see, one can do assisted hatching on day 3, on day 4, on day 5, or on the day itself before you do the biopsy of the cells. But you can also biopsy zona-free embryos. It is a slightly different technique, but you can still biopsy those, so no worries when you have zona-free embryos. A high-quality dynamic laser is to be used. Why? Because it is just technically way much easier if you can indicate where you want to laser and not have to move your dish to the laser point. Also, the latest generation laser has really low heat noise, whilst the older generation lasers will have some heat noise. So also the cells around the area you're lasering will suffer from an increase in temperature. It is not advised to use acid thyroid or a needle because with these two methods, you do not know precisely how large that opening will be that you are going to make. You will need to invest also in some extra equipment at the pipette level. For example, your biopsy pipettes are exclusive for each embryo because we want to avoid cross-contamination of cells between embryos. Also to avoid stickiness, because when you reuse a pipette for biopsy, it becomes more sticky. And here we give you two sizes, a smaller and a slightly larger one. It's for you to decide what works the best for you. The holding pipette is the same as for your ICSIs, except for when you do zona-free embryos, blastocysts. There we advise a smaller inner diameter. To handle the cells, it is really important not to use the mouth pipetting because cross-contamination contamination from the operator to the sample does exist if you use that method. And you need to change also, you have to have an exclusive washing handling pipette for the cells. As for the embryo, we advise to take a larger handling pipette, because these embryos now have an open zona and you can flush them out of that zona, for example, or you can induce collapse if your pipette is too small. When we are doing the biopsy, we're working outside the incubator. It's the same as with ICSI. We want to reduce and minimize the stress to these embryos as much as possible. Standard, you need to have stable pH, stable osmolality, and stable temperature. That's why prepping the dishes is really important, equilibrating and validating how long in your system these need to be equilibrated before you use them to do the biopsy in. Do not use calcium magnesium free medium. That is specifically for a day 3 cleavage stage or more or less stage biopsy, because there we want to reduce or completely remove these tight junctions and adherent junctions between the cells, which is not the case in trophectoderm biopsy. And also a really important step that needs to be added is the witnessing. There are more steps now that need to be double witnessed. Some can be done electronically, but still some will need 4 eyes principal witnessing. And this is when you bring the embryo in and out of the dish in your biopsy dish, when you bring it back into culture, and when you do that, also important cell prep plus tubing, bring them in these PCR tubes that will be shipped to the genomics lab. We will also have to have a witness when you receive the test result to do the interpretation and not make a mistake in the embryo that you will transfer. Mistakes have been made, unfortunately, in the past, so learn from this. Make sure you are 2 operators to check the test result. Go to your tank, record in your system with a witness which embryos are good for transfer. The biopsy methods, there are different ways out there to biopsy embryos at different stages, as you can see here. This is a really good video paper from Fertile Sterile. I highly advise you to go in there, and for each of these stages, you will see nicely explained how to go about, what the plan is, how large the opening should be, how to go about taking the trophectoderm cells from the embryo. So I'm not going into detail on these different stages, but you as colleagues, embryologists, know this is what we will find in our Petri dishes, but also these are the perfect quality ones, but we will also see, of course, the poor quality embryos. And the technique mostly used now is the laser and flick method. So that means aspirating 5 to 10 cells. It's not easy to calculate or to know exactly how many cells. So 5 to 10 is the perfect number. We aspirate them, we stabilize the cells, we laser just in front of the pipette on the junctions, and then we flick down in front of the holding pipette, and we are making sure that we're really well aligned with that holding pipette, and the cells will flick off, will be cut off from the embryo, as you can see here in this little video. Key then is to slowly remove the cells from the biopsy pipette, and then first of all bring the embryo back into culture after wash, and then focus on those biopsied cells. So knowing how many cells that you're biopsying is difficult. What they tell me is if you think it's 5 in your lab, probably it's 6 or 7 nuclei that they will find in genomics lab. So we're good. We are good, but we're not. You cannot count them exactly, but the range is there, and that is the most important one. So working with your injectors, knowing how they react, how they move is really key. So maintain them well, make sure they are smooth and working, that you change the O-rings in your pipette holder from time to time so there are no air leaks or oil leaks, and then I'm sure you will be able to move the cells easily. To remove the cells from the biopsy pipette, sometimes they are sticky, and then you can give a little tap against the pipette holder, and then the vibrations that you give on this pipette holder will go down the pipette, and then by vibration the cells will go off the pipette itself. So that's really easy to do, and there's no cost to it. Just be careful, don't tap too much. If you are using the stretch and pull, so the laser and pull or laser and stretch technique, then you have more sticky samples than with the laser and flick. So that's also why people are moving away from this stretch technique. And it's also difficult to say how far and how long you need to stretch before you cut up the cells. So the flick is way more efficient in that sense. Now let's zoom in on those cells that you are going to prepare for the genomic testing. Really essential is that you talk to your genetics laboratory, your provider, and follow their instructions for use. If it's different from what you're currently doing, then you zoom in and you update your own SOP, and then you practice, and for sure all will be well. But it's really important to work with their methods that they give you as a guide. Key thing is here, this is the most sensitive part of the whole technique for contamination in the sense of DNA, foreign DNA. So we need to work in that very clean environment. We are decluttering the workstation. We are cleaning with our standard IVF products, but we rinse with sterile DNA-free water afterwards. We take a fresh sleeve of dishes for our washing dishes. We take a fresh vial of pipettes for our washing steps. These can go into the IVF lab afterwards, but never ever take those from the IVF lab and bring them into that workstation. We are going to wear protective equipment so we avoid that we are shedding our DNA and in that way contaminating the environment. So here are some suggestions on cleaning. If you have a separate room for this work, which is ideal, then you can use the products that they use in the genomics lab. But don't use those products in your IVF lab because they are really not good for your eggs and sperm and embryos. You can use EUV, but that only works at a short distance, so you will not sterilize or eliminate DNA in the air. And ethanol is not to be used because it will fix the DNA and it can still be amplified. Also switch off that air flow in your workstation because the workstation has a HEPA filter and that does not filter out foreign DNA. And it will blow that on your work your tubing work that you are doing in there. So these are important tips that I can give you to avoid that contamination. We want to get our sample as clean and as stable as possible in the buffer, so it can be frozen and shipped to the genomics provider. So that means that we are going to work also at room temperature, not to degrade the DNA. The tubes that we are going to use, we are putting them also on a cool block, and we will always close them in between our activities, our manipulations. When we finish, we bring the samples into the freezer, that is a stable freezer, and when we bring them to the genomics lab or we ship them there, this also will need to be on a cold block. We will preload the tubes with 2 microliters of buffer, but I'll talk a little bit more about that in a minute. So I'm giving you an example of a washing dish. We advise to prep 10 to 20 microliter washing drops and 4 washing drops, so you will have 3 washing steps. ESHRE also advises to wash at least 2 times. And I'll show you in a minute in a little video how that washing step can be done. So key here is the witnessing. You can see there is the electronic witnessing tag on that washing dish. And then we will bring the sample here to the first drop. We will expel excess medium. We'll take buffer, go to the first drop, and then bring the sample to drop number 2, expel the excess medium, and take medium from drop 3, and so forth until we are in drop 4. And here, once we have washed, we have a preloaded tube with 2 microliters. That's the case for Cooper Genomics, but check with your genomics provider what that volume should be. And we will then preload that vial that is labeled. We will bring it on the edge of a Petri dish. So never put that on your workstation. That workstation glass surface is contaminated with foreign DNA. And here you can then zoom in with the microscope on the small part with the preloaded volume. You bring in the pipette and expel the cells. They go then into the rack that is then also labeled and so forth. So here is a little video on how to do the tubing. As you can see, we are wearing protective equipment, gloves, long sleeves. The whole workstation is cleaned. Only the equipment that we need is in there, and that equipment is only dedicated to this specific tubing work. At Cooper Genomics, we have a kit where you have a DNA-free tube rack. We have labels, we have the buffer, and we have the tubes, which you will see in a minute. So here we are taking all of that outside of our package. We will check, of course, also the shelf life, the expiry date of the buffer, and the batch number. We will note this on a worksheet in the patient's file. So we can always go back. We have the traceability for our quality control afterwards. And then we are going to take the tubes, really check the quality of the tubes as well, because the DNA that you are bringing in there will stay there forever. The genomics testing lab will add their cocktail for amplification, and they will sample from that tube, but they will not transfer the content into a new vial or tube. So if there are scratches or it doesn't close well, discard and take a new PCR tube. So here we are going to preload. We have labeled the tubes, and we don't preload more than 3 tubes because why? It's such a small volume. And if there is evaporation, that will change everything upstream when we do our amplification process. We close again after we have loaded, and now we're going to prep the exclusive drops for that embryo, and that's the cells of that specific embryo. So each cell group has an exclusive washing dish, freshly prepared before you wash. So this is 10 to 20 microliters of buffer that we're prepping there. We're, of course, also using these DNA, RNA-free tips, the PCR quality. And then we are going to prime our pipette, our washing pipette, first with a medium because the cells are in the medium. Then we take the cells and we move them to the first drop. When we expel the cells and with a little volume, and we expel the excess medium in another area. We take fresh medium, and then we go back and take the cell. So this is a standard washing step, which we will repeat 3 times. Why do we wash? We wash to remove oil, we wash to remove albumin and serum, and we wash to remove cell remnants, debris from the cells, because if these are amplified, then they can give a noise or a poor quality sample outcome. So this step is really important. The oil can interfere with the amplification process, the albumin as well. So here you can see we've placed the tube on the edge of that Petri dish. We are going in microscopically, and then microscopically we observe when we are loading the cells in that small volume. We don't add more than, for Cooper anyway, 0.5 microliter, because they want us to not have more than 2.5 microliter as the end volume. All the details are being recorded, and then we also do a quick spin of the tubes before we close the tubes, close them in this transport rack, and that will be stored in the freezer until we ship it to our genomics provider. You can see the witness being there all the time. It's really important to make not a single mistake at this point. Sometimes, as I said, the washing is really important. Sorry, I have to go back. Yeah, so sometimes the washing is really important. We have cellular debris that is with our cells, our normal cells, I mean intact cells, and we ship them off, and then we get a no result test result back. What does that mean? There are 2 types of no result, and one is there is no DNA. So at Cooper's, they use the primary template directed amplification reaction. They will photocopy, they will amplify from your DNA that you have sent again and again, because the amplified DNA, they will lock, so the template cannot attach to that anymore. We'll go back to the original DNA. So if there is debris or small parts or buds of DNA, it will also amplify that. But if you have not washed well or you have not moved cell DNA into the tube, there is a threshold. They will quantify the DNA. Then they will conclude there is not enough DNA. We cannot progress with this tube. However, as I explained, there could also be poor quality DNA in there. And this is because they upstream, they have specific points where they do quality control. I think it's 3 steps when they do have a QC step. And when the sample doesn't meet that QC metrics, it's the rest is also stopped. And we will get feedback as a test result that the quality was insufficient for interpretation. What do we need to do? We need to potentially rebiopsy the embryo. So does that happen a lot? Esri has given us a benchmark that is 5%. But if we look at the literature, in general, it is around 2.2%. This is a publication from the Cimadomo group. That's 2019. The recent 2024 Popovic paper states 2.4%. But it ranges. So yeah, it really can differ from provider and from center to center. At the moment at Cooper Surgical for 2025, the no result rate was 1.6%, of 0.6% being no DNA in the tubes and 1% poor quality DNA. So what influences now the quality of our work? Esri has clearly identified 7 critical steps in the whole PGT process. 1 is the biopsy of the cells. 2 is the cell preparation for PGT. And then there are the other cells as well, like doing the interpretation of the PGT clinical cycle report. So what are the factors that could influence the quality? Well, first of all, it's the quality of our embryo. If we are biopsying poor quality embryos, then of course this will lead to lower potential for implantation in itself, even if they are euploid. So this data comes from a really nice mega review from Cimadomo. So if you haven't read it, I highly advise you to look at this as well. There is no relationships, at least from the recent data from the Innocenti group that were presented at ESHRE, no relationship between the day of the blastocyst that you do your biopsy and the quality of the blastocyst. So you can biopsy a perfect embryo or a poor quality. There will be no higher, statistically higher, no result rates. And you can see the different days and the different qualities of the embryos listed here below. What about assisted hatching? Will that influence the work? Historically, as I showed you in the beginning, this was the technique to biopsy, do assisted hatching, and biopsy cells are hatching. But now we have the concern that cells are hatching too early. And so proportionate-wise, you will reduce the number of cells in DTE for the implanting embryo, the developing embryo. You will reduce that way more than when you wait until day 6, for example, and biopsy hatching cells from there. 2 presentations at ESHRE also showed that when we do assisted hatching, we have up to 9% fully hatched blastocysts on day 5 and 6. So that again is too early. And it might mean that that embryo has not enough TE cells as it normally should have when it was not hatching. So when do we biopsy? And this is the Popovic paper. They made a review of 37,000 blastocysts from different centers. 60% of those operators use day 5 embryos. 38% work with day 6 embryos, and only 2.2% biopsy day 7. This is normal development. When we look at the poor quality embryos, we can take them to day 7, and some of them will develop to a blastocyst. And of those, roughly 20% are euploid. So again, it's up to your clinic, your lab, and also talking to your patient if you will invest in that prolonged culture, testing these slower embryos. But once you have a euploid, they have a really good chance to implant and lead to a healthy pregnancy. Really important is the number of cells. I already mentioned 5 to 10. below 5 cells, you have really a high diagnosis failure, as you can see here in the Zhang study. If you take too many cells, like 15, 20, then you can see also from that same work, you influence the quality of the embryo. So it's really key to find a good balance between 5 and 10. What we now also know is that we do actually increase some damage. We induce some damage while we're biopsying. And this comes from the most recent studies from the Brussels IVF and from Domingo Muelas. When we do a biopsy, we induce some necrosis at the biopsy site and some apoptosis. That's number one. But also, apparently, there is budding of DNA, so enclosing of DNA, and it's key not to aspirate that budded DNA. And if we do, the washing is therefore so important. What about the time of the biopsy? When we biopsy, is that important? Is there a link with no result? Well, here the study from Innocenti, again, lots and lots of embryos they looked at, couldn't find any link to the moment in the day when they were biopsying, the day in the week, or even the year. So they looked also retrospectively at their data. Some small tips: multiple flicking, scraping the sample against the pipette, and overstretching can lead to no results. It's not clear what is the best method. There's contradictory information, the flick or the pull and stretch. Same for the number of laser shots, although the societies advise to be very conservative with laser shots. We always advise 3 shots. And then the recent study was comparing 3 methods: laser and flick, laser and stretch, and no laser and flick only. And in the last method, they saw that they were taking too many cells, not the amount that they wanted, but because of it is not cut already by the laser, they were taking too many cells. And they also had more necrosis in those samples. But I didn't see any difference on that level between the 2 other techniques. Other tips is if you don't preload, you have an increase in poor results in PGT, meaning poor quality. Washing is really important. Being eye for detail on that specific volume that is requested by your genomic testing lab. And if you don't close the tube, there will be evaporation. And again, genomics lab will run into trouble and you will have poor quality outcomes. Sticking of cells. So make sure you load them into that preloaded volume, and then a little spin, a very quick centrifugation step will make sure everything is pulled down, and that will avoid those poor results. Contamination I described. We can have also foreign DNA contamination. That's also poor quality sample. Of course, cleaning the lab, using the protective equipment for yourself, and switching off that airflow. Sperm could be a potential contaminant. You need to check with your genomic testing lab. But for Cooper, they will not amplify haploid DNA. So there you can use IVF, for example. And when you biopsy, it's no problem if you aspirate a sperm. But you have to ask and check with your provider. One thing we can control is make sure that all the cumulus cells are removed, because they can cause maternal DNA contamination. And we can also control the contamination from a previous embryo. So use exclusive pipettes when you biopsy, use exclusive pipettes when you wash the sample and load it into the tube. So that step is controllable, and no mouse pipetting is really essential. Training is really important, updating your techniques. This is just an example of a training schedule where you will read about your local guidelines, your society guidelines, your legal aspects of this work, and then you start zooming into your own protocols, and you will then start shadowing your expert biopsier. You can go externally and shadow in other clinics. You can go to a training center and work with mouse embryos, and then you start biopsying yourself in a training model with donated embryos, with the expert guiding you. Key is, of course, that your lab manager assigns you to this training time, that they offer you time to get trained in this technique in the biopsy, but also in the tubing. Once you've been signed off, you can start doing 1 embryo in a cohort of 10, then if that works well, 2, 3, and so forth. But it's more than those two techniques. There's also setting up the laser, testing the microscope, prepping the dishes, the witnessing steps, the paperwork. So it's not only the high precision techniques that you need to master, but everything around that as well. And here I give you some examples where they really were able to get all their operators aligned and work at the same level. This is from a multi-center group where you can see 7 different operators, and they use as KPI to check if operators were doing well the pregnancy test and the ongoing implantation rate. And it was similar in all these labs, which is great. They also looked at the no result rate. There was statistically no difference. We have 2 studies here, as you can see, but I would, for example, this operator 7 has higher no result rate. I would ask this person to sit with, for example, operator 3 and go through the procedure and see where it differs. It's not statistically different, but there is a trend to having more no results. So monitoring of your outcomes, the quality manager has a big role in this to see if everybody is doing well. And when are we doing well? Well, Escher has given us KPIs, and I'm listing them here. Survival of the embryo, 24-hour survival of the embryo, positive signal in the tube and a negative control in the tube, and also your contamination rate can be checked. Once you're in the clinical work, of course, there you have your implantation and ongoing pregnancy and healthy baby at home, but also correct test results between the test results of the embryo and the baby that has been born. So let's summarize. A lot of information I've given you. This technique, TE biopsy for PGT, requires a high blastocyst development rate, optimized culture system, excellent vitrification system. Otherwise, PGT will not help you. It will negatively impact the work you are doing for your patient. It may require changes in your workflow. Different time points of biopsying is possible, but also one biopsy moment is also now being done way more. Witnessing is very important during all these steps, as I try to demonstrate to you. And I haven't talked about vitrification, but what we don't, this is still lacking in the literature. What is the best way and moment to vitrify these biopsy embryos? The jury is out there, so best is to use your own method that you already have in place. And once that works well, you can validate other methods to vitrify. Training is mandatory, and you have to check if you're doing well by using key performance indicators. The quality of the biopsy and your cell preparation techniques can definitely influence the PGT result and the embryo viability, of course, but also the test result. And if there is poor quality DNA or no DNA, then you have to rebiopsy. So I think I've listed all that can give you an excellent way of working in cell preparation for PGT. Should you want to find more information, I'm listing you here some guidelines, but I do know that you also have great guidelines in India. And then we also have at Cooper Surgical, we have a knowledge hub, we have different webinars also on how to work with the laser, how to go about working with your microscope. So you can go back and check that freely. It's available for everyone. And also this how-to video is on there. So voila, thank you very much. And I'll stop sharing. I'm happy to take questions.
Thank you, Martine, for such a wonderful session. It was quite elaborate, and I think you covered all the aspects of biopsy, right from biopsy to tubing and keeping quality controls and other parameters, the training parameters into consideration. So yes, it is very important that the training should be given for each and every step of biopsy, not just the biopsy, but the tubing as well. By the time, yes, now we welcome all our attendees to post their queries in the chat box. We will start taking questions one by one. And Meanwhile, just wanted to ask you, just intuitively came to my mind that we have been doing for its regarding the biopsy. So we have been giving the laser shots while before flick method. We apply flicking method as well as giving the laser shots. So do you recommend that we can, is there any way that we can avoid giving the laser shots and directly do the flicking method, if especially if it is hatching?
Yeah. So if you have, if you're working with day 5 embryos and you have the exact amount of cells that are hatching, 5, 6, 7, you don't need to use the laser. That's number one. But if you have more cells, you really need to laser, because you want to define where these cells are going to be removed. So you will laser on the junctions right in front of your pipette. If you are using day 6 embryos, the tight junctions are harder, so for sure you need to laser. And you can also laser through the pipette, but then you will reduce the intensity of the laser. And then you need to flush out your sample so that that laser part is right in front of your pipette. I do hope that's the answer to your question. And we always advise to give 3 shots. Just distribute them between the front of the pipette, or if you're doing the pipette, just 3 shots. Yeah. And try to avoid lasering, like for a zona-free embryo, you need to best laser in the pipette, otherwise you might laser also cells that are sitting under your laser area.
Yeah, so the laser should be used judiciously and not just giving the shots like going too many shots at a time. Okay.
And that becomes, I think, pretty important advice with lasers being so advanced and multiple options and sizes being available. At times people do use laser their way, and that may affect the sample in a way.
The sample, yes, and also the embryo. Because as I said, there is heat noise. If your intensity is too high, and how does the laser work? It's not an intensity per se, but it's the time of exposure. So you set it to 0.2 microseconds. And if that is like 1 microsecond, that's like a huge heat bomb, actually. And then the cells in your embryo will also be exposed, which is not good, and the DNA in your sample. So if it's best to validate also the whole size with the microseconds. So you can use a zona pellucida from a degenerated oocyte, and you just laser and you change the settings, and then you write this on a sheet, and you know, okay, for me, I want a 2 micrometer or 4 micrometer opening. My intensity will need to be 0.400 microseconds. It's really easy to do. Yeah.
I think we can start taking up the questions.
Yes. We already have a few questions in the chat box. To start from first, Khalil has asked, why is contamination control so important for accurate epigenetic and genetic testing? Is it important? I think it's 2 sentences.
Yeah, so contamination control is important because the platform in the genetics lab, the enzymes, they will amplify any form of DNA. So if you have foreign DNA, like my skin cells when I'm doing the tubing, or my colleagues, then that will amplify, and you will get a really mosaic outcome, and we cannot draw any correct conclusion from that. We will see it's contaminated. So it is really important to work in this DNA-free environment. And if you have this poor quality outcome in your test result, then you need to rebiopsy, which is extra stress on the embryo, because you need to warm it, rebiopsy, revitrify, and then warm. And it works. There are several publications out there, but it's totally not the way to go about our work while we can avoid this contamination.
So it's very clear that we have to be very meticulous while working on a biopsy sample, especially once we are doing the biopsy and tubing, because a little of contamination that can hamper the results and that can give deleterious effect on the results. The next question is, how do genetic mosaicism and sampling error impact the accuracy of genetic testing results?
How do genetic mosaicism and sampling error impact the accuracy? Well, as I just explained, mosaicism, well, I'm not a geneticist, number one, but we have to avoid to create this by foreign DNA contamination. So if it is maternal contamination, it could look like a form of mosaicism, and then they need to do parental testing to see if it is from the mother, that's mosaic streak in the result. So it is really important. Again, we can control this, remove all the cumulus cells, for example. Yeah. Genetic mosaicism and sampling error also. There's just a nice study was done to look at where is it safe to biopsy, close to the ICM, far from the ICM, and in fact this study shows you can biopsy very close to the ICM. I wouldn't do it. I try to avoid it, but if you have no other option, you can do that. That's what the study showed, and there was no increase in mosaicism.
Okay, there are the cases I think where the cells they are already hatching out near the ICM. Yeah. So in those cases, I think you need to do the biopsy from those cells.
Yes, or you could make a second opening, which is actually, if you look at this fertile sterile paper, they show you how to do this, and it's easy to do once you know how to go about it. So a second opening away from the inner cell mass, and you biopsy from there. If you have done this, you have to write this in the patient file for that specific embryo, because when you want to transfer this embryo, you have to make a large opening so that you will not induce monozygotic twinning. And this is something I saw in the recent data, that in fact we do have more monozygotic twinning when we do PGT biopsy. So to avoid that, when we don't want a Mickey Mouse, so we will remove a larger proportion so the embryo can escape through that large opening after transfer and implants.
Oh, that's very important.
Right. I don't think so many of them are aware of how the genetic results are actually decoded by the bioinformatics or the expert, because not every company gives that entire 46 chromosome, the noise and the levels which is being decoded. And that is where actually people come to know that how the chromosomes are seen, when it goes up and when it goes down, how to report it. And that's the reason might be we have the questions at the initial level, that they're unaware of the effects of contamination in the reporting. So.
Yeah. So there are different ways to go about the interpretation of the results. I do know at Cooper's, I was totally not involved, but a few years ago they introduced AI, so they realized that the operator, the geneticist, can also make a mistake in reading those spikes and deviations. And they have like 10,000 euploid embryos DNA, and they compare then the DNA from that specific embryo that you're testing. And in that way, they could really objectively define if it's euploid or mosaic, etc. Yeah. So yeah, but each provider works in a different way. But this is, I think safer if somebody like AI in this system apparently work really better.
Sure, AI is everywhere now. What's drafted through AI. So we can maybe take the next question.
Yeah. So is it fine if you couldn't see the biopsied material go into the tube, but you are sure that you pushed out all the content into the stripper tip? Of the stripper tip.
It is fine. You couldn't see the. Yeah, this is sometimes tricky, especially I find if it is biopsies for structural rearrangement, chromosomal rearrangements. These embryos tend to have more lyses in their cells, but it is really important, number one, that you have a good stereo microscope. High quality, it needs to be higher quality than observing an embryo when you are working with these few cells. So making sure you know how to work with the stereo, play with the mirror, so you can play with the shadows or more contrast with the cells. If you are not sure that the content, that the cells are in the tube, then you have to write this on the worksheets and the patient's file, and you might want to go for another biopsy. Because if you have to rewarm the embryo, it's way more stress than doing a fresh rebiopsy. And sometimes it's tricky to see, but most of the time you see the cells come out. But your equipment is key, and also your eye, the training, what to see, what to look for. For example, when you biopsy, how I train is, you finish biopsy, go to the stereo microscope, locate the embryo, but also at the same time locate the cells. You see a little gray prop of cells. Take the embryo, don't mingle in that area with your pipette. Take the embryo, wash, and then go back to that position. Prime your pipette before you take the cells, so not with a dry pipette. And keep them in the tip of the pipette. Don't aspirate them too far. So be in control of seeing and manipulating the cells.
Great, yeah, so that's pretty clear instruction. I hope that answers your question, Nisha, that yes, train your eyes, have a nice set of equipment, and have the sample at the tip and train it so that you can always understand that it has been pushed, because confirmation is always better than giving a dice. So, I mean, having the confusion.
Yeah.
So I think going forward to the next question, the first part you have already mentioned, that if there is no detect, can we re-perform biopsy? And how many times, and you have said that yes, it is always stressful to thaw and do the re-biopsy, and it may affect. The second part of this, second part of the question by Nibaj asks that if the oocyte quality is poor and we only have 1 or 2 blastocysts, can we still perform re-biopsy?
This is a very good question. So from the data, if you have no, let's start first. You have no DNA or poor result DNA outcome. What the data show is if you rebiopsy, you have roughly 96% in the cases you have an outcome, you have a result, a test result. So for 4% of these embryos, you will not have a result, inconclusive. So then you need to discuss with the patient, shall we transfer without the result, or what do we do? But it's really important. So that means the embryo, the rebiopsy has a chance. And when you look at the data of the transfers of rebiopsied embryos, almost 1 and 2 of those embryos that were euploid, that were transferred, result in a pregnancy. So I do believe it is really labor intense and probably stressful as well, the stress on these few embryos for the operator, but it's worthwhile to do. But you have to bring in the patient and counsel them, because rebiopsy, good embryos seems not to have a big impact. Poor quality embryos do suffer from the rebiopsy. So they need to be aware, and you have to make an informed decision with them. The genetic counselor needs to be there. You with your data on what will be the chance that I have now an outcome, and what will be the impact on the embryo. It's a tricky one. It's a very good question, but it's not only the lab that will decide what the policy will be, the strategy will be for these embryos.
Right, so it will vary from situation to situation, and you need right counseling and the transparency with the patient for such situations.
And the patient should be informed about the outcomes, the probability of the outcomes. Coming on to the next question, Sujala, she is asking that tubing is to be done at 37 or room temperature.
A room temperature. But you have to check with your provider. But normally it's room temperature because, as I said, we want to keep that DNA safe. If we keep it at 37, the DNA will start to degrade because it's not in living cells anymore. There is no active metabolism protecting this DNA in this outside environment. Sometimes I see people accumulating dishes with biopsy cells, and then they go tubing. I advise against this. Biopsy and prep your cells, biopsy and prep your cells. Ideally, you are 2 people managing this. one person is focusing on the biopsy, the second on the cell prep and the tubing. They can be witness, they can discuss the strategy for the biopsy if something is not going according to plan. So 2 people is perfect in this setup. Yeah. And then these samples don't have to wait while you are going to, when you are going to do the, bring them in the protected buffer. Yeah.
So when you say that 2 people are there, so one is the performer and the other is the witness system, witnessing
Yes, one is doing the biopsy, and the other person can then double check. Okay, you have taken embryo 1 into your biopsy dish. Then this dish goes to that other person, and this person now can witness that the cells go into tube number 1. So it's really the most efficient way, I think, with 2 people, and it gives a nice continuous flow as well. Because if you have to do all of this alone, it takes so long. Yeah.
But otherwise, the tubing should be performed by the same person who has done the biopsy, right?
No, not necessarily.
No, it's not necessary.
No.
Okay.
So next question which we have, you did answer it, but maybe it's also with regards to day 5, day 6. The recommended laser shot for performing trophectoderm biopsy, you mentioned 3 shots to the west, but on day 5 is
what should be he's asking what should be the intensity, the
laser shot size.
Yeah. So the intensity I cannot say. I can only say that you should have in your laser system, you should be able to create a hole size between 2 and 5 micrometers. And then you need to check in your system what the intensity is. I know what it is on my laser, but you need to validate.
Basically, different lasers, they have different parameters and different intensities.
And even in your own lab, you have the same laser on 2 systems. It could be slightly different. So you need to validate this whole size calibration. Yeah. Easy done.
You will have to see that how much intensity is required to have a shot of around 2 to 5 mm.
Exactly.
Yeah. Right.
I remember in our days we used to validate with the oocytes which are not fertilized for some of the patient, isolated, remove, check the laser shot, the intensity, calibrate accordingly, and then go ahead for the biopsy.
So exactly. Perfect. You also have to check each time before you start for that patient if your laser is hitting where it is supposed to hit. Yeah. Because sometimes somebody touches the camera and then already it will shift a little bit. So that you check the temperature and you check the lasers if it's doing what it's supposed to do. And you can use ideally that with the a donated degenerated oocyte, a zona pellucida, from an oocyte.
I think that actually connects us with the next question, because the next question was a similar line. Which control check should be performed on laser calibration before starting the procedure?
Okay.
Also, what are the measures that can be taken so that biopsied sample doesn't stick to the stripper tip? To a certain extent, you have answered that. Yeah, but please can the first part of the question. What control check should be performed?
What is the final question?
What control check should be performed on laser calibration before starting the procedure?
Yes, that is really important. You have to do this like on a monthly basis, but also prior to the start of your work that day. As I said, in the lab, I dust the equipment before visitors come in, and I'm not in a human IVF, in a mouse IVF training lab, and sometimes it's not hitting where it's supposed to, and then the camera has shifted or something has changed. So you really want to make sure that your laser goes where you want it to go and not on ICM cells or whatever.
Right. So I think probably we are coming to the last question of the evening, and one more question. Suman's question: in what objective magnification biopsy is usually performed? So in what objective magnification is biopsy usually performed?
Okay, so at different magnifications. What we always advise is we like to have a dish with 3 biopsy drops. a top drop we use to prime the holding pipette and the biopsy pipette. And then we also test how the aspiration works. That's just, and then we do a dry flick before we go into drop number 2, the middle drop, where you have your embryo waiting to be biopsied. So you know your system is working well. You could add that zona in there and do that test for the laser in that first drop as well. What was the question? Sorry. I had
so what in what objective magnification
yeah, okay.
is biopsy usually performed?
Yeah, so that is being done at 10 times, not more, 10 times magnification. You need to have an overview of everything. You want to see the meniscus go up and down and see how it reacts. So that's lower magnification. Then you clamp the embryo, lower magnification. And as you can see behind me, that is already at 40 times. And it depends on what laser magnification, what magnification your laser is included. Normally, this is a 40 times as well. And then you laser, but you always go back to lower magnification to do the flick because you want to have the overview of the pipettes, the menisc, the cells going left, right, whatever. So it's moving with the magnifications.
Martine, just to ask you, do we have some more time because the questions they are really popping up, and does the time allow you to answer a few questions? Maybe.
I think I can take 2 more questions, but then I need to go into another meeting. I'm so sorry.
Right, sure. So.
Yeah, so I think one is fully hatched blastocyst. Post-thaw, should we wait for full expansion since it is without zona perista?
Yes, so fully hatched blastocyst, you have to wait until it is expanded. And then you take a holding with a slightly smaller inner diameter. You aspirate gently. Actually, you don't even have to aspirate zona free, but you can. And then you aspirate the cells that you want to biopsy. You laser through the pipette. You flush out a little bit so that that part is in front, and then you flick. Yes. So expansion, you want to make sure that you differentiate from ICM and TE cells. If it is collapsed or yesterday I learned folded, some people call folding embryos. You have to wait until you can really differentiate those 2 cell lines.
And now coming to the last question for the evening. What is the typical waiting period for embryo freezing following a biopsy to achieve optimal results? Yeah. And for how long should the embryo be maintained in the equilibration medium?
So this is a really, really good question. And as I briefly touched on, I fear that I cannot give you any recommendation at this very moment. The studies that are out there, they did different biopsy methods, that they biopsed different number of cells. They made different openings in the zona. They used different cryopreservation protocols, vitrification protocols. What I do see is that if they are used to work with collapsed embryos to vitrify, they will start working after 30 minutes before they re-expand. If they are vitrifying with non-biopsied embryos, then they will wait until there is re-expansion. And they will go into culture medium, not equilibration medium. They will go back into culture to wait for this expansion, and some then induce collapse. So best is to check what you do and use that in the beginning. If you are happy with these results, you continue. Some wait 2 hours. As I said, some start after 30 minutes. So unfortunately, the good laboratory practice for this is not still defined. And I'm really sorry for this, but I wish I could help. But you all have good vitrification methods. Start with that. And if you want to introduce like collapse or non-collapse, validate first on a cohort of patients before you apply it to all the patients. It's really important.
So it is otherwise it is recommended that within 30 minutes is the best time. to refreeze.
Well, yes, this is what one study says. This is from the Rienzi, the Italian group, but others say 2 hours. So, yeah.
So everyone has to set their own benchmarks, and that is the best thing that can be done.
For now, yes, yes.
Right.
The only thing I can add to this, perhaps, is if you do this with zona-free embryos, you need, when you load on the device for vitrification, you need to add a little bit more cryopreservant because they don't have a zona. And if it's very thin, it could be damaged. And also the timings should be shorter for equilibration. So this is a special group for vitrification.
So this ends our today's questions session, and although it was a very interesting session and it was going very smoothly, and it's very difficult to say bye when such sessions happen. But now the time has come to thank you. I really thank you, Martin, for taking out time from your precious routine and giving such an elaborate talk on how to excel in cell preparation for PGT, and as well as answering all the questions from different attendees.
Well, it was my pleasure to be here, and I do hope that I could demonstrate some good laboratory practices. More than happy to answer some questions. You can always go via Vakil or clinical application scientists in India. So more than happy to guide you further.
Right, great. Thank you so much. Thank you for your time. Thank you, Cooper Surgical, for arranging this session. And thank you all attendees for being here. We'll come across with another such beautiful session next month with
on 29th. We are probably on 29th of September. We will meet again with another speaker and another insightful session. Till then, goodbye and take care.
Thank you. Bye-bye. Have a good night.
Bye. Have a good night.